Welcome to Myth versus Medicine, our live discussion with scientists funded by the Breast Cancer Research Foundation, Dr. Veronica Jones, breast surgeon at City of Hope, and Dr. Ivanthia Roussos-Torres, breast oncologist at the University of Southern California. My name is Sadia Zapp, and I am the Managing Director of Communications and Content here at the Breast Cancer Research Foundation. I was also diagnosed with breast cancer at the age of 36. Now, luckily, when I was diagnosed, I'd been working at BCRF, so I spoke breast cancer fluently. I didn't need to search anything online, but unfortunately, that's not the case for a lot of women. In fact, a study that BCRF released just this morning found that nearly half of US adults, 2 out of 5 women, have never searched for breast cancer online. So I'm sure very often patients who are diagnosed have a lot of Googling to do, have a lot of searching to do. So we're going to get into that. But first, let's get started with a lightning round of true or false for our audience. There's got a poll that's going to share where it's going to pop up, and I'd love for you all to just answer, see how much. I'm going to test your breast cancer knowledge. Let's start with the first one. Most people diagnosed with breast cancer have a family history. Mammograms are not effective at detecting breast cancer. Using deodorant or antiperspirant with aluminum causes breast cancer. And how common is breast cancer in women? We'll give everyone a couple of seconds to answer off of the top of your heads. Okay. Let's see what the polls reveal. How much does our audience know about breast cancer? Okay, most people diagnosed with breast cancer have a family history. A lot of people said true. The answer is false. About 85 to 90% of patients have no family history or genetic mutation. Mammograms are not effective at detecting breast cancer. Some people said true, but it is in fact false. Mammograms are the very best tool we have right now to detect breast cancer. Using deodorant or antiperspirant with aluminum causes breast cancer. The answer is false. There is no evidence to point to this being true. And our very last question, 1 in 8, yes, most of you know the right answer. 1 in 8 women will be diagnosed with breast cancer. It actually makes me feel really good that we are aware of just how common it is. So I want to dive into the study I just mentioned. More than ever, people are doing their own research. BCRF launched a social first campaign. I did my own research, highlighting the scientists that are literally doing their own research, like Drs. Roussos-Torres and Dr. Jones. And what does that mean in 2026? So some of the most significant takeaways from our survey found that about 68% of Americans still name their doctor as their most trusted health source. Yay, very good news. But younger Americans are twice as likely to put their trust in a search engine or an AI tool compared to older adults. So that very much tracks. We know that compared to 77% of adults over 55, 55% of adults 18 to 34 trust an AI tool or a search engine. Another key fact that I want to hone in on is that more than 1 in 4 adults who searched for breast cancer information online have found something that directly contradicted their doctor. And among 35 to 54-year-olds, the core mammogram screening demographic, 35% found something that directly contradicted their doctor. Now, that's not always bad news, but we're going to talk about why that is. 39% of Americans have made a doctor's appointment after finding health information online. 20% saw a second medical opinion. I think what's really interesting is that 7% of all US adults say that a social media post directly inspired them to schedule a mammogram or breast exam. And that rises to about 11% among women 18 to 34. I think that's really powerful because it indicates that social media can be a powerful tool for good to drive positive behavior. So on the other hand, I want to talk about a study that was in the New England Journal of Medicine last year, co-authored by a BCRF funded investigator. reporting that 70% of patients under 40 were dissatisfied with their care. And I'm talking about specifically breast cancer patients because they encountered delays at three pivotal crossroads, whether the clinician ordered tests and dismissed the individual as too young, whether imaging modalities were sensitive or not. We know that younger women are most likely to have dense breasts, or whether their biopsy confirmed or missed a cancer. I'm drawing this parallel between this study that talks about how 70% of younger patients were dissatisfied with the care they received, with the fact that younger people are more likely to go online to search. It's an important connection because what we're finding is that as more younger women are being diagnosed, they have to do their own research. They're finding that they must learn more about the disease in order to advocate for themselves properly. So today, it's really about that idea. Sometimes doing your own research is critical to your health. So how do we do that well when there's so much misinformation online? So first, I do want to point out, please do feel free to submit questions in the Q&A. We will try our best to get to all of them. Please remember, no personal medical questions, but otherwise we will do our best to answer as many as we can. So Dr. Jones and Risos Torres, when patients say, I did my own research, what does that look like in your exam room? Let's start with you, Dr. Jones.
Yeah, first, thank you so much for having me. I'm very excited to be here for this discussion. I think it is extremely timely. Um, so when patients come into my office, so I'm a surgeon, right? And so typically that means that they've researched online and with friends and family, which is a very important factor in terms of what type of surgery the patient wants or thinks they need. So I have some patients who come to me and say, I did my own research. I want a mastectomy, right? Or removal of the whole breast. Or I talked to my friends and my family and I want both of my breasts removed. And I actually welcome that and love that because I think that we have to have that discussion to know, okay, what's informing your decision making and how can I just enhance that with medical knowledge and help you come to a decision that is right for you, but also based in the research that's done, right, about mastectomies and lumpectomies. So usually in my clinic, it's research from friends and family, from the internet, and we use that as a starting point for our discussion.
Fantastic. And what about you, Dr. Risos Torres?
So I just want to echo and thank you for having us here. This is tremendous. It's so difficult to be here to be able to have these discussions. And I'm a medical oncologist, so I usually see patients after they have seen someone like Dr. Jones, or that the breast surgeons are typically who the patients are seeing before they come to my office. And when they come to me, they've usually had some conversations about, the research that they've done either through talking with family and friends or on the internet about the surgery that is being discussed. And they're coming to me to talk about the systemic therapy that might or might not be part of their treatment plan. And when, I usually, try and make and clarify, what is my role? Systemic therapy means the kinds of therapy that's going to reach all over your body, right? It's going to go through either through your veins or in form of a pill, but it's going to reach everywhere that blood touches. And and I also clarify the role of systemic therapy in their treatment course, right? Like this is to get things that we can't see on scans and to prevent things from coming back, not only in the breast, but in other places. And then just like Dr. Jones mentioned, a lot of times people are coming with research that compares what, other people have gotten to what we're discussing about their specific case. And so certainly putting it into the context of, personalized medicine, and we really have to let's understand what kind of breast cancer you have, and then we can address your questions and how how that compares to what you've learned from talking to other people. The other thing I'll just mention as a nuance is that now people are not only telling me that they looked things up on the internet, but actually specifically AI. ChatGPT told me X, or Claude told me Y. And I think And I welcome that. I mean, I'm starting to learn how to use this in my practice and in my research as well. And so what I typically try and, point out and discuss with patients is that this is great. Your AI actually there's a lot of really wonderful, powerful things AI can bring to us. But what's really important is that you make sure you're asking the right questions to AI, and not only the right questions, but really asking for AI to use trusted sources to give you answers, because it actually is. I welcome the knowledge. I want patients to come having read and learned and have been informed. I feel like it's my job to help them understand, okay, you know what? That's great. And that was a great starting point. I think it's really important next time to use sources like PubMed, which is where we go for our peer-reviewed research, and where all of our clinical trials are posted. And those are the really trusted sources. And if you instruct the internet and AI to use those sources, then the kind of research you're coming in with is quite valid. And so I
Mhm.
think that's really important to educate our patients about, and just help them learn how to use these tools to come in with questions backed by, the reading that they've done.
Mhm. And I'll add that at BCRF, we launched a new section called About Breast Cancer that answers so many of these because we saw this growing need where patients were turning to sources online and not being sure about what was real and what wasn't. And all of the information on our site has been vetted. So we've done all the homework, we've done all the work. So our scientists have all reviewed the information that we post on our site. So always know that BCRF is here for you, especially if you have a loved one going through a diagnosis or are experiencing one yourself. So, Dr. Jones, I want to also step back. Let's talk big picture. What's changed the most in our understanding of breast cancer in the last 5 to 10 years? If you had to pick some of the biggest changes that you've seen, I know there are so many. What would you say, especially since you're the first stop for a lot of patients?
Yeah, and you're asking in terms of like in breast cancer research and breast
Yeah.
cancer treatment, what has changed? Okay,
Yes.
so I think that we have focused a lot on personalized medicine and this word de-escalation of
Mhm.
care. And so before we used to treat breast cancer with like the biggest and the most, right? Like the most surgery that we can do
Mhm.
and the most medicines that we can give. And then specifically in the last decade, that has really been tailored to, okay, how can we limit toxicity? How can we withhold medicines that are not really helping patients or do less surgery? Because we know that these bigger surgeries don't accomplish the goals that we were trying to accomplish, right? And so that's been a major shift, I think, in the treatment of breast cancer, in that everything is becoming much more specific, much more tailored. We're being thoughtful about how all of these different therapies, surgery, systemic therapy, radiation therapy, intertwine, and how they can work together to help the patient. Maybe where can we pull back and where do we need to give more?
Mhm.
And so each patient is so unique and the cancers are so specific that we're trying to tailor the medicine to that patient and that specific cancer and withhold the treatments that aren't going to benefit someone.
Mhm. And I'll add, I think one of the most profound changes over the past several decades, because of what you just mentioned, that personalized medicine, is that we've seen a 44% decline in deaths from breast cancer since BCRF was founded, driven primarily by precision medicine, focusing
Mhm.
on what is happening to that individual patient. So we know that the research works. Dr. Musos Torres, what's a headline people see online that's often misleading or oversimplified?
So I came up with a, couple examples to think about this, as I was, getting ready for this great talk that we're having here. And I think one of the most common ones I see, scientists discover cause of breast cancer in young women, or mammograms, you know, friend or foe. And then another one is something, things like, if you eat or, do, this type of exercise enough? You can prevent breast cancer. So those kinds of things. I think the primary one, I mean, I think you nailed it when you asked the question, that are oversimplified. So it's not that these studies or these headlines are fake. It's not that they're trying to, trick anyone. It's just that they dramatically overstate what the science has actually showed. So I'm sure that this article that comes after scientists discover the cause of breast cancer in young women, I'm sure this links to a study that has found something that contributes to the cause of breast cancer in young patients. But it's not the cause. It's not going to be one, this is not it. So I think that's, what people see and they kind of glom onto.
Mm-hmm. Well, for both of you, I would love to ask, we talked about how there's this giant statistic about 70% specifically of younger patients that don't feel heard. What do you recommend a patient should do if they truly feel like their concerns are not being heard by their care team? Dr. Jones, any tips?
Yeah, that's such a tough situation. And my heart just goes out to patients to be in that position because it's such a vulnerable position to be in. Um, I do think that there is power in second opinions because this is a journey and you do need to feel comfortable with your provider. So if you don't feel comfortable with your provider, if you don't feel comfortable expressing questions because maybe you don't feel heard when you have tried, then I do recommend my patients, all patients, to seek a second opinion just to find that right fit for you in terms of the confidence that you have to have in your care team providing for you as you're going through this journey. So that is typically what I recommend. You don't have to stay in a situation where you feel undervalued. So.
Dr. Torres, Dr. Russo Torres, anything from you?
So I would entirely agree with that as the primary thing I would say. The other thing I would add is sometimes it just takes a moment to actually recognize that you feel this way with your provider. And if you feel like you actually have connected with your doctor and maybe they just didn't pick up on the fact that you don't feel heard. So I would actually take a moment to voice that concern and just say, you know what? I really feel like you're not hearing my concern. Would you mind if we just took a few minutes at the end of, every visit to check in on whether or on some, concerns that come up during the visit and, introducing that pause in the visit or actually just voicing that you feel that way to your provider will just help them understand that they might need to have say things differently or explain things in a different way to help address the concerns you have.
Yeah. I'll add that as a patient, some of the tricks that I've learned is that sometimes it helps when I have questions leading into my appointment is to message it via the portal ahead of time and say, like, these are my questions I'd love to cover at our next visit. And a lot of times doctors are way too busy, so they're reading them as they're walking into the room, which is fine, but at least they're mentally preparing themselves or their nurse to read my questions ahead of time. And of course, trying to make it a conversation so that the relationship stays positive with your doctor. And one final thing I'll add is, especially as a patient, I think a lot of doctors, and Dr. Ruiz Torres and Dr. Jones, this may or may not be you, but doctors, I think, also unconsciously maybe try not to scare patients and will not maybe list every single thing that may or may not go wrong. So sometimes patients have to be the ones to voice, this is what I'm feeling, this is what I'm experiencing, because they might not have the time or ability to tell you, you may have X, Y, and Z happen to you, because it doesn't happen to every patient. It just happens to happen to you. So I would say just voicing concerns is number one, just telling your patient, your doctor, what you're experiencing. So I'm going to now turn to questions that were submitted also by the audience. Let's start with risk and diagnosis. Dr. Russo's Torres, does these are going to be some of these questions are going to be a little bit specific, but does atypical hyperplasia increase your risk for cancer? Can you tell us
So
what that is first?
yes. So atypical ductal hyperplasia or atypical lobular hyperplasia, those are both different kinds of hyperplasia. They are not breast cancer, but they are what we call high risk breast lesions or high risk, breast masses. And they basically signal that the breast tissue has developed biologic changes that are associated with a substantially higher chance of developing breast cancer later.
Mhm.
So, to be clear, atypical hyperplasia is not cancer, but it's one of the most important benign breast findings that inform us about some future risk. So we use it to trigger, a formal risk assessment. We closely review family and genetic history or genetic risk. We optimize their screening, make sure we're doing the right screening, and then we discuss, prevention options. Sometimes there's a role for what we call chemoprevention, taking a pill, and then certainly when in the case of atypical hyperplasia, there's a role for surgery. So sometimes that's part of, we involve this discussion as a multidisciplinary team and, make sure the patients and understand what we're talking about. Why does this increase the risk? And then, there are many things we do about it. And there's, of course, statistics that go along with that. And so oftentimes some people like hearing the numbers. So we'll go through like, okay, how much does this increase your risk at 5 years, at 10 years? If you have this atypical hyperplasia?
hmm And Dr. Jones, I'm going to pivot. I'm just building off of that, what you just mentioned, Dr. Russos Torres. We've also received a question about DCIS. I know DCIS can be a confusing diagnosis for some people because it's treated as a cancer, but they're also told it's non-invasive. So, Dr. Jones, can you first tell us a little bit about what is DCIS and sort of what's the controversy and how we're approaching patients with DCIS, otherwise known as stage
Yeah.
zero cancer?
DCIS is controversial, and I will say it's not just controversial for patients, it's controversial among providers as well. And so there's a lot of discussion about how to optimally treat DCIS, and all DCIS is not the same. So what DCIS is it stands for Ductal Carcinoma In Situ. It is considered a non-invasive cancer, meaning it cannot spread outside of the breast. So it doesn't go to lymph nodes, it doesn't go to other organs. And so that's why there's all this debate about whether it should be called cancer or not, because it cannot travel, it cannot spread anywhere. It's kind of local to the breast. But they are malignant cells. They're just kind of trapped inside the ductal tissue and don't have the ability to escape the breast. So there's a lot of debate about how to treat it. Fortunately, there are some wonderful clinical trials that are open that help us determine the best way to treat ductal carcinoma in situ. And it will look different for every patient. There's some DCIS that looks very aggressive and similar to invasive cancer, and that we have to treat differently, right? We may treat that with surgery and radiation and medicine, as opposed to maybe a very small, non-aggressive DCIS that could be treated on a clinical trial with medicine alone or observation. So there is a lot of heterogeneity around the DCIS term, and that's why there's so much controversy as well.
Mm-hmm. Thank you. I wanted to also, as we're talking about risk, one of the questions that we received was around sort of family history. So one of the very first questions we asked in our quiz is that family history does not indicate all the time whether or not you're at high risk for breast cancer. So don't take a lack of family history as I'm safe, I don't need to worry about it. But when there is a family history, does prostate cancer in a first degree relative, for example, merit concern when it comes to breast cancer, or does it flag the need for genetic testing? Would you guys have any points of view on that?
I mean, I would say that any family history of cancer, no matter what kind it is something that we closely pay attention to and is part of the history that we take. And we're always discovering different, there's always new inherited mutations that are discovered that, link these types of cancers together. And there are many that we know about already. So I would certainly say it would not be dismissed. I mean, I think the most important when we're asking about family history, we're asking about, breast cancer, but there are a lot of different inherited mutations that actually increase risk of multiple types of cancers.
Mhm. Mhm.
So certainly prostate cancer is one that we pay close attention to and can be part of these familial inherited risks.
Mhm. Thank you. Dr. Jones, another common question when it comes to increasing risk, and Dr. Russo-Torres, please also chime in if you know more about this, but does IVF increase breast cancer risk?
That's a great question. So we typically advise all of our patients who are young breast cancer patients to actually seek just fertility counseling.
Mhm.
And so that is part of our treatment paradigm is to recommend a fertility conversation. And for those patients who are interested and eligible, they actually do undergo egg harvesting before we start treatment
Mhm.
because that has been shown to be safe. And it also has been shown to not delay the breast cancer treatment. And so I only bring that up to mention that it's something that we're even mindful of as we're doing the treatment for the
Mhm.
breast cancer. So it's not something that we shy away from. It's not something that we try to tell patients not to do. It's something that we encourage, and it does not increase your risk for breast cancer. Even if you have breast cancer, we
Mhm.
can still encourage you to undergo fertility conversations.
I think that's so important, especially as we're talking more and more about breast cancer in younger populations, primarily because the issues that they face are so unique and different than the experience of breast cancer later in life. And this fertility is the number one concern, second only to surviving, right?
Yeah.
So
Yeah.
I think it's a really important point to make that IVF is actually safe and should be discussed with your doctor as a newly diagnosed patient. Dr. Russos Torres, and this is a question that we've received several actually in the chat. What are the most powerful ways to reduce the risk of breast cancer and breast cancer recurrence? Is there a silver bullet of something we should all be doing and taking? Is there a supplement we should be taking?
So I mean, there's two parts to this question, and they're both very, very important. So the first part is reducing the risk of developing breast cancer.
Mhm.
So, you know, it's it's actually not flashy at all. The answer to this question is very straightforward. Maintaining a healthy weight,
Mhm.
especially after menopause, regular physical activity, and then something actually my mom always used to say, everything in moderation. So, that includes the things I just mentioned, maintaining a healthy weight and physical activity, and things like alcohol and certainly avoiding habits like smoking. So it's really not, this is not new. And that's really what we have to kind of really focus on in terms of reduction of risk of developing breast cancer. There isn't one thing and that we should all be doing or not doing. It's really, a healthy life. And that's where we're at right now with what we know. That actually these things actually have proven to reduce the risk of developing breast cancer. It's not just a mantra to live by. There's evidence. And then reducing the risk of recurrence after a diagnosis is a different question. And so what I really want to, hone in on is what is the part of the therapy that I'm responsible for patients is completing the prescribed endocrine therapy in the case of patients with hormone receptor positive disease. That is one of the most important things people can do to actually reduce the risk of recurrence. That is the purpose.
Mhm.
And it is not a small ask. These are not, this is not like taking a sugar pill. I mean, there are side effects to endocrine therapies, absolutely. But it is one of the best things that we can do to reduce that risk of recurrence. And then in addition to that, it's maintaining these, unglamorous things like exercise, weight management, limiting alcohol, smoking cessation. But it's the evidence-based treatments that we recommend that there's evidence to really back that this is what we can do to reduce the risk.
I think I want to dig a little bit deeper into a couple of things that you mentioned, which is there's a new tool in the toolbox when it comes to weight management. Can we talk a little bit about what we know around GLP-1s and its role in helping us achieve that goal?
Absolutely. This is a question I've been getting all the time as of recent. It's a great question. So as of now, there's really no clear signal that GLP-1 drugs increase the risk of breast cancer. This is something we are heavily researching. So, this is something that we are going to get more information over time. But I would say at this point, I wouldn't necessarily tell a patient not to go on a GLP-1 because there's a concern for a breast cancer risk based on the current evidence that we have. But I mean, I'd probably frame it as such to say, at this point, the research is reassuring thus far. But long-term, breast cancer specific prevention and survivorship data are still maturing. We're still collecting this information. So I mean, there's been a number of studies done, even, in the short amount of time that these drugs have been available, that have really shown that there's no increased risk. And so newer cancer-wide analyses are underway, and we're going to keep following these. So, but I think as of now, there's no specific risk that has been identified.
And another question we received in the chat, and I think it's a really good one to get to, is you mentioned how, especially for HR positive breast cancer patients that are on long maintenance therapies that can last anywhere from 5 to 10 years, I'll be on an aromatase inhibitor with ovarian suppression for 10 years. And there are a lot of side effects. To say the least. So I'm curious, if there's are there any new treatments on the horizon? I know we've talked a lot about BCRF, these selective estrogen receptor degraders or SERDs coming down the pike and promising information for early stage breast cancer patients. Nonetheless, before I turn it over to you, Dr. Russos-Torres, is to just highlight again, tell your doctors about the side effects because they can't help you if you don't tell them what you're experiencing. And for so much of these side effects, there is something to be done about it. There almost always is some option to help you through them. So that's my 2 cents as far as HR positive breast cancer patients and side effects goes. But Dr. Russos-Torres, any other options that you think are coming down the pike?
I mean, I think this is a really important question. And I think especially the drug companies have started to pay more attention about, development of endocrine therapies that do have fewer side effects, especially as younger women are being asked to stay on these drugs for, at least a decade, if not longer. And so I think that I mean, I won't name any specifically that are on the horizon because there aren't any that are on the verge of, being approved. But I do think that at least we've gotten the attention of the drug companies that this is something that patients really want. And I think for now, unfortunately, because of what the drugs do, which is block estrogen, right? The side effects are really a result of what the drugs are successfully doing to prevent recurrence, which is, decreasing the amount of estrogen circulating in your body. And so it's not even necessarily that the drug is causing the side effect. It's that the drug is successfully doing what we want it to. And that is actually the effect, the quote unquote side effect, but it's actually an on target effect. We want there to be less circulating estrogen, but as a result, there are these horrible side effects that patients have to deal with. So I would echo exactly what you said, Svia, that talk to your doctor about the side effects that bother you most. And maybe you didn't realize that it was, tied to the endocrine therapy, hair thinning, fatigue, the inability to fall asleep at night, insomnia. These are things people may not tie to their endocrine therapy, but very much are related. And there are things we can do to help to address those effects of the estrogen withdrawal. And that actually significantly improve quality of life. So, and I think we're really starting to do more of this. And so I would encourage people to really talk to their doctor about those side effects that are bothersome.
And
Yeah.
one last note that I'll add is that at the AACR meeting a couple of weeks ago, the American Association of Cancer Research, I think that's right, one of our BCRF funded investigators shared information on postpartum breast cancer. And what postpartum is if you have been diagnosed with breast cancer within 10 years of having a child. So basically, when you're diagnosed, if you have a child less than 10 years old, that sort of places you in this category of postpartum. One of the things I want to point out to patients, it's so important to follow your treatment protocols and listen to your doctors on the best ways to minimize your long-term risk because postpartum breast cancer patients are specifically at higher risk for recurrence than an average breast cancer patient. So it's one of the things we heard at AACR, but I just want to drive home why what Dr. Russo's Torres said is so important to stick to your treatment protocols as best you can and still maintain that quality of life as much as you can. So we're going to pivot a little bit now to talk about questions on screening, detection, and monitoring. Dr. Jones, what are symptoms breast cancer survivors should keep an eye out for when it comes to recurrence? Would we benefit from full body scans like the ones we have celebrities doing online?
Yeah. Um, I I will answer that question. I
Mhm.
just wanted to piggyback on something Dr. Rosas Torres shared, and she shared so many great things um, for the symptom management, also in the survivorship period. Just wanted to highlight that there also may be clinical trials available
Mm,
specifically for the symptom management
mm,
as a side effect of the endocrine therapy. So it's just something else to mention to your care provider if you like definitely voice those side effects, but then also ask if there's any clinical trials available to help manage some of those things like joint pain, hot flashes. Um, and then with respect to symptoms to look out for in the survivorship period, I usually advise my patients to be aware of their body, right? So if they have a new rash, if they have a new finding of redness, a new lump, things like that, that I want to know about it as soon as they notice it. And similarly, if they have like a new pain somewhere, like, oh, this part of me never hurt before, but now it's a very focal pain in this part of my bone or hip or something like that. That's something else to be aware of. And to discuss with your provider because they will be able to pick the right screening test for you. I would say one limitation of kind of full body scans is that they are a bit general and not very specific. And so if you have a specific complaint, usually your care provider will order the test that is best suited to investigate that complaint, right? So if you have something new in your breast, the answer would not be a full body scan. It may be a targeted ultrasound. It may be an MRI, and your care provider would be able to guide you toward the appropriate screening test for you. And so that goes back to having that great relationship with your care provider where you can express those symptoms as they arise.
mhm.
Mm.
And speaking of what you just mentioned, there is a new tool that a lot of patients online have heard a lot about, which are ctDNA tests or liquid biopsies, or otherwise known as blood tests that you can get. Really, they're available to patients now. It's a little bit of a controversial topic because if you ask your oncologist, my oncologist at least says, absolutely not, we're not doing it, right? Because there's nothing we can do about it. So I would love to, Dr. Russos Torres, how are you hearing about it and how do you approach the idea for patients that show up and say, I heard about this blood test, I want to take it to monitor for recurrence. What is your point of view?
So, this is a great question. Just so that everyone's on the same page, circulating tumor DNA, ctDNA, what it is that it's tiny little fragments of tumor-specific DNA that can be found in the bloodstream. And how it's being studied and the way that we even thought to look is that it can actually identify what we call minimal residual disease, whatever's like minimal, exactly what it sounds like, leftover breast cancer, or other kinds of cancer. And so the way it has been initially studied is in its ability to predict relapse at a substantially earlier time point than a scan would perhaps detect. And so the idea is that the lead times would be, much sooner, rather months as opposed to years, to look for metastatic recurrence, recurrence outside the breast. Um, I want to clarify, there's also something called circulating tumor cells, CTCs, and that is different from ctDNA. The CTCs are actually tumor cells that are whole cells. And that is not what ctDNA are, these little fragments of DNA from the tumor. So those are different things. And it's the ctDNA where there's tons of really great evidence coming out about the sensitivity of these tests to detect minimal residual disease and or recurrence at earlier time points. So what I would say to patients, and what I do say to patients when they ask for this, the main issue at the moment is we still do not have standardized management protocols. There is no universally accepted protocol for how often we should check for this. What is the threshold at which it's positive? What is the intervention timing? Like if we detect it, what do we do and when? And what should be the imaging that we do in response to this kind of a test? So I think that's the main issue and one of the main reasons we don't just order it at the drop of a hat, because we don't have good guidelines as of yet to react.
Mm-hmm.
So at the moment, the way it's being used is for metastatic breast cancer, we can monitor, and we're doing this in many, many clinical trials right now to monitor disease response. And for early stage breast cancer, after patients have had curative therapy, we're monitoring ctDNA to try and understand what should those thresholds be? What do we find when something comes up? Whether is that considered positive, or is it not positive but detectable? And what does that mean? And what should we do? So the way I like to do this is in the context of clinical trials, because there are many, many, many clinical trials for ctDNA right now. So whether you're a survivor or a patient who has therapy, who's in the middle of therapy, or someone who has metastatic disease and is undergoing constant therapy, there are a lot of opportunities to participate in clinical trials trying to help come up with these guidelines for ctDNA. And I'm always happy to try and find that for my patients so that I can justify ordering it in a way that will guide me with what to do when I get a test back.
Mm-hmm.
And I think that's where we're at right now. We're not at the stage where we know where we should really just be ordering it at the drop of a hat.
Mm-hmm. So you both have mentioned clinical trials now. So I just want to ask do you have any recommendations where patients might find clinical trials on their own?
Yeah. So one great source is, of course, your care team, right? You can ask your care team and they can look to see what institutional clinical trials are open. But there's also clinicaltrials.gov, which lists clinical trials that are sponsored. So, and that is a way, I would say, to try to find what clinical trials are available nationally. That way, if there is something that maybe is not available at your specific institution, your care provider can kind of refer you to where you could benefit from that clinical trial. But
Fantastic. Thank you.
Yeah.
Now,
And I would just add, sorry, I would
yeah.
just add to that a great way to do that is if it's a little, it can be very daunting to go on clinicaltrials.gov.
yeah,
And I actually tried this with a patient the other day. If you go on ChatGPT and ask ChatGPT or your favorite AI bot, whichever ones you like, please use clinicaltrials.gov to help me find clinical trials for and put in your diagnosis or your specific what you're looking for. And then you can use that to help guide your research and then bring that to your care team, to
yeah.
your surgical oncologist or medical oncologist. And that's kind of a way to siphon or narrow the discussion. And also to get more explanation and not feel overwhelmed by the terminology on clinicaltrials.gov.
Yeah. That's a great point.
Thank you. So I want to use our next 10 minutes very wisely. So I'm going to pepper in some questions we've been getting from in the chat as well as the ones we received beforehand. So pivoting to treatment, Dr. Jones, is a double mastectomy better than a lumpectomy when it comes to reducing recurrence? You talked about this earlier as far as that's one of the first questions patients ask of you, but I want to couple that with a second question there, which is what should specifically metastatic breast cancer patients consider also when it comes to surgery and whether or not it's right for them?
Great questions. So I'll take the first one. Um, in terms of is a double mastectomy better at preventing recurrence than a lumpectomy? Um, the very short, oversimplified answer is no. But I will say that this is a very individual decision, and we take into consideration so many factors when we are deciding the best surgical approach, such as your risk of a future development of cancer, how the cancer was detected, the size of it, all of the biomarkers or like the profile of the cancer. There are a lot of things that go into that decision. And so I will say that it is not that a double mastectomy is always better than a lumpectomy, because that's where that shift has come in breast cancer management, where we understand now that the more we do is not always what's best for the individual. And so some patients may benefit completely from a lumpectomy and radiation, and that is the best treatment for them, better than a double mastectomy. So it's very individualized. Our lumpectomies plus radiation have comparable survival to a mastectomy, and in some cases, maybe the preferred approach. So it really does depend on the person and on the tumor. Um, and then the second question, which was also about the role of surgery in the metastatic setting, such a great question. We had the American Society of Breast Surgeons annual meeting a couple weeks ago, and this was a very hot topic. We talked about the role of surgery. It was actually one of our great debates at that conference. And the the jury's still out on which cases are best for surgery in the metastatic setting. It is absolutely a multidisciplinary discussion, meaning the surgeon does not make that decision in isolation. It is a conversation with the medical oncologist, the radiation oncologist, and the patient to determine if it's appropriate for them. Again, usually we will consider it if there's limited metastatic disease that is well controlled with medicine. But that, again, may be oversimplifying it because it is very personalized. But there could be a role for surgery.
Thank you. Dr. Russos Torres, okay, we need to discuss something. Well, first, I'm going to ask you a couple. I have several questions for you, but one of the questions we received in the chat was, what are some of the biggest, well, let's start here. We're going to start here. What are some of the biggest misinformation points you're seeing stemming from social and search that makes its way into your office? We talked a little bit about this at the beginning, but are there any specific things people are coming to you about with, like, do mammograms cause cancer? Do you know those kinds of questions? Anything that you're seeing specifically?
So one of the things I'm getting a lot of, which maybe part of, other questions that have come up is actually hormone replacement therapy.
Yep.
Is it okay for me to take hormone replacement therapy, especially in perimenopausal women who are, about to, not in menopause yet, but, are about to go into menopause. And so many people are now, asking about HRT. And so something that has come up a lot. And I would say the misinformation really is around the fact that systemic hormone replacement therapy it's the same answer for everyone. It's not the same answer for everyone. And I think that's the major point I want to make. This is a conversation that has to be based on who you are and what your health, what you're dealing with. Have you had breast cancer? Are you high risk but have never developed breast cancer? Or do you have the same average risk that, in the population risk for breast cancer, in which case systemic hormone replacement therapy, it might be fine, but that's not necessarily the answer for someone who had invasive breast cancer, in which case systemic hormone replacement therapy is generally avoided. Maybe you didn't have hormone positive breast cancer, you had triple negative breast cancer, right? So that's another part of the conversation. Okay, well, there is, that it's not as much of a risk for that patient. Maybe we're talking about someone who's still high risk, but not. So again, it's a very personalized conversation. So I think the misinformation is that there's a blanket answer for
Mhm.
every woman, and the
Mhm.
answer is there isn't. It really needs to be a conversation.
Thank you.
So
That was my that was going to be my third question is HRT. Everyone is talking about hormone replacement therapy and whether or not breast cancer patients can take it. I think what I'm hearing from you is generally no, especially for hormone receptor positive breast cancer patients. But still, if you've had triple negative, all of these conversations need to happen with your doctor and your individual case.
And the other thing I would say, just to point out, it's the systemic, the
Yes.
pills of estrogen, right? We
Yes, can
can
we talk about that? I would love to hear your point. Tell us the
yes.
difference. You're talking about
Okay.
systemic versus local.
So systemic, as I kind of tried to define before, it means when you take something that goes all over your body. So if you take a pill, that is something that dissolves and goes into your bloodstream and it kind of bathes your whole body in whatever that pill had, right? Versus local. So for in hormone replacement therapy terms, that would be like vaginal estrogen.
Hmm.
So there are ways in which we can address some of the things that hormone replacement therapy hopes to
Hmm.
help by doing something that is more local. Low dose vaginal estrogen is something that I have,
Hmm.
given to patients who've had hormone positive breast cancers before,
Hmm.
because there's minimal systemic absorption when you give it that way.
Hmm.
Um, and that's not to be confused with medications that are delivered as a transdermal patch, which is
Right.
still systemic.
Yes.
So I know the terminology can be very confusing. So that's why it's very good to ask these questions. So when I'm saying that we like to avoid systemic hormone
Hmm.
replacement therapy in patients who have had estrogen and progesterone positive breast cancers, there are a number of ways in which we can give systemic therapy. And then the
Hmm.
local therapy are in the forms typically of, vaginal gels,
Hmm.
creams, even suppository. I mean, sometimes that works more locally for some of the symptoms that we're
Hmm.
trying to address. So I
Yes.
think the key message here is it's not a simple yes or no. It's nuanced. And so it just has to be a conversation.
Hmm. I think it's also debunking the myth that all HRT is wrong for patients because vaginal estrogen can be such a game changer in symptom management to keep patients on their endocrine therapy for much longer. So
Right.
it's also one of those things that educating healthcare teams of the safety protocol around local vaginal estrogen versus systemic. Okay, so thank you so much for that. Now, of course, I'm going to ask you the question that we're going to talk about, but one question I get all the time. And just 2 days ago, a New York Times report indicated a massive jump in prescriptions for ivermectin and fenbendazole for cancer patients. So many people ask me this. Do you hear this a lot? And what do we know about it?
Yes, so I found that New York Times article. I've read it a few times now. And then there's also a number of articles. There's a JAMA oncology article that came out about this whole topic of conversation. So I'm going to start with the bottom line and then I'll work my way backwards. So ivermectin and there's febendazole, some of these other azoles. These remain experimental hypothesis generating agents in breast cancer, which means there's no strong published human clinical evidence showing that either of these drugs improves survival, shrinks tumors, or should replace standard breast cancer therapies. So that is the key here. There are a lot of studies that are being done in petri dishes in the lab in animal models to understand the effects of ivermectin on breast cancer cells and subsequently tumor growth and progression. But we do not have evidence that suggests in patients that this should in any way, shape, or form replace the gold standard of care that we practice because we don't have that information. And so that is what I want to make sure is understood because the conversations I've had with people are that they want to do this instead of what we've discussed and what we're recommending. And the major difference is we're recommending things because they were studied in large, well well designed and controlled clinical trials that show us that the medications we're using and the interventions we're recommending change survival and improve outcome. And that's why we recommend them. And that's why we're doing this. We don't have that evidence for ivermectin and for bendazole. We don't know that. So for someone to choose that over what we have evidence that works is it's scary to me and heartbreaking because I would not want that for my patients. I want them to live. I want them to live long lives. And I don't these drugs they don't do that as far as we can tell.
Mm-hmm. And I think it's important because driving back home to the survey results that BCRF conducted, when we hear that 1 in 4 patients have had contradicting information online versus what their doctor tells them, on one hand, it could be a young patient who knows that she needs to take changes to her body seriously, even though the doctor told her she was too young. On the other hand, it could be patients that were told that are hearing certain podcasters tell them that ivermectin cured cancers and contradicting what their doctor is telling them. So that this is where we're talking about making sure you are doing your own research and finding evidence-backed information, and that's what BCRF is here for. So we are coming up on time, and first I want to give you two the opportunity. Are there any closing thoughts you'd like to leave our audience with?
I would just say that I think a theme of this talk today has been that your treatment is personalized and individualized. And the more the better relationship you have with your care provider to share things that are personal to you that you are going through, the more we can individualize your treatment and meet you along this journey. So I think that's just the one takeaway that I would share from this. It was just such a lovely opportunity to be here and to share this space with you all. But yeah, that was it.
And I'll just add to that because I echo all of those things. And I would say, you know, as a physician, I fully endorse that knowledge is power. I would love I went into this field because I love how much patients want to know about their cancer and how we're going to treat it and what we can do. And I love that curiosity for knowledge and desire. And I think what I would say has also been a theme that I would love people to just remember, just make sure you're getting the knowledge from reliable sources. And I always send my patients to BCRF's website because it's so nice to go. You can go to that section that says for patients, and it has all the all the questions patients have right there written in a way that patients can understand. And then it links to the research. And, we've talked about some of the ways if you want to read more, you can go into that. You can find those articles if you want. They're there. And then you can have those conversations with your doctors. We're here to talk and help everyone learn what we've learned and what we know and what we don't know and how we're going to fix what we don't know.
Yes.
We love having those conversations.
Mhm.
Dr. Jones and I've talked about this. This is what we love about breast cancer in general and patients who have breast cancer have this desire to know as much as they can. And we love that. And I think that really drives us to keep doing our research and to, have the conversations we do with patients. And so I would say, I would never want anyone to stop doing that. But I think just make sure you're going to the right places for that information.
Well, thank you both so much for your time. I know, Dr. Jones, you're in between patients, you're in clinic today, so I really appreciate you jumping on with us today. And same, Dr. Rizos Torres, we really appreciate getting your perspectives, being two sides of a coin that a lot of breast cancer patients will experience, both a surgeon and an oncologist. So we appreciate your time today, and thank you. We will be sharing this video online, so please do share it with anyone you think might benefit, and keep an eye out for more talks from BCRF. Thanks, everyone.